Good morning, good afternoon, good evening for everybody here. Uh, we really would like to thank you for being with us this morning because I think today's topic is really very important. And we witnessed the importance of this through our practice in the musculoskeletal aspects of hemophilia around the world. Ultrasound diagnosis and imaging is becoming more and more important, particularly for the early detection of any bleed or any intervention of the synovial membrane in the joint. And for this, we are very pleased today to have this webinar organized by the WFH Musculoskeletal Committee, which is chaired by our colleague from Argentina, Dr. Carla. Our speakers today are Dr. Carlo Martinoli, Dr. Gianluigi Pasta, and Dr. Dario Di Minno, which is the three of them are very well-known figures, either in the musculoskeletal orthopedic or in the imaging of using the ultrasound. Having said that, I would like just to welcome our three speakers and give this to Carla, who is our chair of the Musculoskeletal Committee. Carla, the floor is yours, please.
Good morning, good afternoon, good evening for all of you. I am Carla da Funchio, the chair for the Musculoskeletal Committee. And on behalf of our committee and the Humanitarian Aid Program, it was a really pleasure to organize this musculoskeletal webinar. Thank you, Carlo, Dario, and Gianluigi for your participation. And it's a pleasure for me to introduce our speaker, Professor Carlo Martinoli, who is a very well-known professional in his field. He has a long CV, but to mention a few, he has served as a president of the European Society of the Musculoskeletal Radiology and the creator of HEDAS. That is the very useful method for monitoring the joint, detect the early signs of joint damage, and help us to improve the quality of life in persons with bleeding disorders. Thank you, Carlo, for that.
Thank you, Carla. And if I can start, I would like to thank Carla and the organizing committee of the World Federation of Hemophilia for giving me this great opportunity to speak on the HEDAS system. I share my screen. And the title of my speech today is More Than 10 Years of HEDAS. And it's true because the first paper published in the literature was dated 2013. But I started 3-4 years earlier to understand the needs of the hemophilia doctors and the possible role of ultrasound as an adjunct to physical examination for a more adequate visit of the joints of these patients. So this is my disclosure, and starting with the history and the role of joint ultrasound in this field. The first point was the recognition that ultrasound is actually able to disclose disease-specific findings, and I refer to the two main domains of the disease process. And they are, on one side, the disease activity, and on the other side, the osteochondral damage. And ultrasound can identify some findings that may be part of these two domains. And using ultrasound to disclose these findings, ultrasound has a role to define the status of the affected joint. So in addition to the ability of ultrasound to disclose these specific findings in hemophilic arthropathy, it's also important to consider other advantages in the application of ultrasound in this field. The one of them is the fact that that is a very rapid test, so it's ideal for multi-joint assessment. It is able to provide a very quick examination of the 6 joints, and this is a great advantage because in the room where you visit patients, you can provide you can have information not only on the symptomatic joints, but also you can check, if you wish, the asymptomatic ones to have a global idea of the status of the joint in your patient. In addition, ultrasound is not an invasive procedure. It doesn't use ionising radiation, and so it can be repeated, so you can check and recheck findings, and you can use ultrasound also for follow-up and longitudinal evaluations to understand the evolution of the disease process. These are very important points, and emphasizing the potential of ultrasound in this field. In addition, ultrasound is a fantastic clinical examination because you have a continuing relationship with the patient. The patient, you can perform some clinical maneuvers when you examine the patient with the probe, and at the same time, you can also invite the patient, you can interact with the patient, inviting him to give a look to the screen, to discuss findings on the screen. This is absolutely great. It's a great way to transmit the clinical information. The decision to prepare a system like the HEDAS one that is a point of care system. That means a system performed and interpreted by the clinician and not by a radiologist. Was for the most related to the fact that in the busy practice context of every day, the real need is to have a very quick check of the joint status for the hemophilia doctors, for the hemophilia center regarding patients, reducing the time to send the patients to imaging departments, trying to get an information that may be useful in terms of patient management when the patient is still on the examination bed. So this is point of care, and the EDA system was specifically designed to have a focused, very decision-making strategy to answer specific questions or to identify the biomarkers I mentioned before, without the need to for a more detailed and more comprehensive examination like the radiological examination of a joint. So it's a system based on the detection of disease activity. So the point is to understand if the joint examined is a joint in which there have been some bleeding episode in a recent past or not, and at the same time to identify early osteochondral damage, just to be aggressive with the therapy strategies, in the order to reduce the risk of a bleeding in that joint, and at the same time to identify osteochondral damage when it's an early damage and not a late damage. So to do that, we decided to design a system that is easy to learn, even for a non-imaging expert. And this is an important point because ultrasound, before the advent of EDAS, ultrasound was used a few by clinicians in the hemophilia centers. This in the with the objective, with the aim to complement physical examination, to be something like a stethoscope to increase the accuracy of physical examination, not only in the identification of acute bleeding episode, but also to provide something like a quick screening tool to examine the sixth joint of interest in hemophilia. So, and the system is named HEDAS, and HEDAS means hemophilia early arthropathy detection with ultrasound. The word early is very important because it was specifically designed to create something that is simple, easy to learn, easy to perform, even if the machine you have are not high-end machines, to have an information on an early damage. So at the same time, a simple system doesn't mean non-informative. So the system was designed to give information about the status of joints and the disease. It was also designed to be repeatable longitudinally to be able to monitor the efficacy of treatment and evolution of damage in longitudinal studies, and to be very, very, very rapid. So time efficient to be implemented in the daily activity. And today, using the EDAS system, we are able to demonstrate pathology or to exclude it in the joint of an hemophilic patient in 1-2 minutes. So the very quick tool to be used in the room where you visit patients. And the kind of information provided is not very detailed, but black and white, salt and pepper. Is there activity or not? Is there any osteochondral damage at the level of the articular surfaces of the three joints or not? Very simple information. So you know that in the first paper published in 2013, you know the scanning planes we used for the three joints, the elbow, the knee, and the ankle. Here, the scanning planes are listed. Each of them is named, as you can see here. If you refer to the elbow, you can see on the right-hand side of the slide an image, an ultrasound image showing the two recesses, the radial and the coronoid recess at the level of the anterior aspect of the humeral diaphysis. And this is a scanning plane to identify if there is something distending these recesses in terms of activity. The E1B plane is a bit more inferior than the previous one. And this scanning plane, the aim is to evaluate the osteochondral surface. This is the wavy osteochondral surface of the distal humeral epiphysis, and you can identify the cartilage layer in black, and the subchondral bone has a very smooth bony surface there. Then the probe is rotated vertically in a sagittal plane, and it's placed over the radiocapitellar joint and the trochlear joint, just to confirm what you already saw using the first two scanning plane. In this case, the aim is to identify if there is something pathological at the level of the recesses, and also to give a look again at the osteochondral surfaces. And the ultrasound image On the right-hand side of the slide, you can see the humeral capitellum, and here is the image of the humeral trochlea with the coronoid process of the ulna. Here is the coronoid recess of the joint. The list of scanning planes is completed by a posterior mid-sagittal plane over the olecranon fossa to examine the last recess of the joint. So 5 planes is to obtain 2 kinds of information. So these planes have the aim to examine one osteochondral surface, the most exposed for ultrasound in the joint, and on the other side, these scanning planes evaluate the recesses located around the joint to identify if there is any distension by effusion or by synovium. Moving to the knee, we have a very similar protocol, starting with the K1 scanning plane and an anterior mid-sagittal ultrasound image at the level of the quadriceps tendon. You can see here the position of the recess, number 7, in between the 2 fat pads, the suprapatellar and the prefemoral fat pad. This scanning plane is completed by the evaluation of the parapatellar recesses, K2A, K2B, and these scanning planes allow the evaluation of the joint in terms of joint distension. Then the osteochondral surface selected for the knee joint is the trochlea, is the femoral trochlea, and this is the seagull appearance of the femoral trochlea, in which you can see a thick slab of cartilage and the smooth subchondral bone. And K4 is the last scanning plane obtained on the medial side of the femorotibial joint at the level of the medial meniscus, just to check the status of the joint surfaces to identify if at this level we have prominent osteophytes, if the meniscus is extruded, and if the joint space is thinned at that level. The ankle is not very different from the previous joints, and it's the scanning technique starts with the A1A scanning plane that is located just lateral to the midline axis in the sagittal plane to examine the anterior aspect of the talus. You know that the talus is formed by 3 parts. The talar dome covered with cartilage, talar neck is concave, and then we have the talar head in a more distal position. In this image, you also see the tibia numbered as 1. You see the position of the joints line numbered as 7, and here is the position of one of the most important recesses of the ankle joint, the anterior recess. The evaluation of the osteochondral surface of reference is performed placing the probe transversely over the joint, and you can see here the hyaline cartilage covering the talar dome together with the smooth appearance of the bony surface there. After that, the examination is completed by checking the sinus tarsi, in which we have the 2 recesses opening there. One is the recess coming from the proper subtalar joint, and the other recess comes from the talocalcaneonavicular joint. It's not important for our need to make a difference. The important point is to understand if there is a recess distension at the level of the groove of the sinus tarsi. And finally, the posterior scanning plane obtained posterior medial to examine the posterior recesses of the tibiotalar and subtalar joint. So the scanning technique, you know, it's easy for the 3 joints. The number of scanning plane is 4 or 5, depending on the joint to be examined. And the point is that this system require to be very, very systematic. You have to place the probe in the exact position over the joint to make the examination reproducible and to reduce the inter-observer variability. So remember that the ankle in general is considered the most challenging of the three joint to score. And remember that there are also some trick of the trade to make the examination more accurate, more adequate, even if these points are not described in the original article. Remember that when you place the probe over the sinus, tarsi, it's important that the probe is not placed to too dorsal, but it's very important that the probe goes down in between the two bony walls of the sinus. This is the lateral process of the talus that is located posterior to the sinus. And then we have the lateral side of the talar head anteriorly. And it's important that the probe is placed transversely here, but you have to go down until you reach the calcaneus, because in cases of milder distension, grade 1 distension of the recesses, if you place the probe too dorsal, you can miss these findings. Similar thing is when you perform the A3 scanning plane, that is considered the most difficult in absolute. So when you have to place the probe posteriorly to scan the posterior recesses of the tibiotalar and the subtalar joint, remember a list of things, a shopping list of maneuvers to do to obtain a good image. Dorsiflexion of the ankle is important, but don't forget to avert the ankle. If not, the quality of the image is not good on the screen. Then the probe has to be placed vertical in close contact with the medial malleolus, tilted 45 degrees, halfway between coronal and sagittal planes. And then you have to move the probe from proximal to distal and circumscribing the posterior edge of the malleolus to image the two recesses, the posterior recess of the tibiotalar and the subtalar joint. So remember these points. They are very, very important to improve the quality of examination of the ankle. Regarding the scoring scale, remember that the scoring scale was designed to be as simple as possible. And again, the scoring scales include items related to disease activity and to osteochondral damage. Regarding disease activity, we decided not to score a fusion because it's a fluctuating parameter, and we graded synovium in a three-step scale. Considering osteochondral damage, remember that the evaluation of damage is obtained on the anterior aspect of the distal humeral epiphysis in the elbow, on the femoral trochlea in the knee, and at the level of the talar dome in the ankle. In any case, the transducer is placed transversely over the osteochondral surface, and when we believe that the scanning plane shows the maximal extent, the maximal severity of the damage, you have to freeze the image on the screen, and you can score the cartilage in 5 degrees and bone in other 3 degrees. So cartilage is scored from 0 to 4, bone from 0 to 2. Remember that the EDA scoring scale is an additive scale with the values ranging from 0 to 8, and we can mix the items related to disease activity and osteochondral damage together to obtain a total score, but we can also consider subscores for activity or subscores for damage, just in case you would like to emphasize the one of the two domains regarding the scoring scale. Remember how to score. There are some rules we use to score the synovium and the recess distension at the level of the three joints. Here you can see an example of the elbow. And when you have to score the elbow, remember that it's important to identify the level of the recesses. Then if to distinguish grade 0 from grade 1, you have to refer to the shape of these recesses. If the recesses are concave, it's normal. If they are convex, of course, is more than normal, is something that has to be indicated in the report. And then when in higher grade distensions, when you have more abundant synovium at the level of the joint, you have also to check the area located superficial to the capitellum. At this level, if you see that the synovium forms a bridge between the recesses and the joint line, you realize that the amount of distension is not moderate but is severe. Here you can see the E3 scanning plane, that is the posterior one, with the different shapes to be recognized. Remember, for scoring, you have to group the anterior recesses in one, and we can call this recess anterior recess, and then you have to consider separately the posterior recess. So in case you have discrepant findings, because these recesses are more or less equivalent with each other, remember that the final score is the highest value, regardless the position. So if you have a discrepant value in the anterior and posterior recesses of the elbow, anterior is grade 2 and posterior grade 1, remember that the final score is 2. Similarly, if in the anterior recess the score is 1 and for the posterior is 2, the final score is 2. In the knee joint, we have a different situation, because in the knee joint, the suprapatellar recess is much bigger than the parapatellar ones. No, remember that if we see something distending the recess at the level proximal in between the two fat pads, touching the undersurface of the quadriceps, but not extending more proximally, this is absolutely normal and is so commonly seen in normal population. If we have a higher degree of distension and the amount of synovium is such to open the space between the quadriceps and the prefemoral fat pad just proximal to the level of the suprapatellar fat pad, is grade 1. But when the full amount of distension is wider than the width of the probe you use, this is grade 2. And in this case, you have to evaluate the parapatellar recesses as well. Basically, you have to group the lateral and the medial parapatellar recesses in one, and you have to score the suprapatellar and the parapatellar. But if you have a discrepant finding, and the parapatellar is 2, for instance, and the suprapatellar is 1, remember that the suprapatellar is dominant because it's much bigger, is much more important, and so in terms of scoring, the final score will be 1 for the knee. In the ankle, it's very similar, because in the ankle we have to evaluate the tibiotalar and the subtalar joint. Here is an example of grade 0, grade 1, and grade 2 for the tibiotalar. You can see something distending the recess in blue, and if the distension is located at the level of the joint line or in the pocket pocket at the level of has a pocket at the level of the neck, but not enough to create a bridge over the osteochondral surface of the dome. Remember that this is normal. When the amount of synovium is able to elevate the fat pad and to form a bridge over the talar dome is grade 1. And if the amount of synovium is more than approximately 50% of the maximal extent of distension of the recess, this is grade 2. Similarly, we have to, for the tibiotalar, to evaluate the posterior recess, but the posterior recess is difficult to scan, is much smaller, and so if you have a discrepant finding between anterior and posterior, at the end, the anterior recess has to be considered the dominant one, and you have to score to assign a final score regarding the anterior, the value of the anterior recess and not the one of the posterior recess. For the for the subtalar joint, remember that we have two joints opening there. One is the proprioceptalar, the other one is the talocalcaneonavicular. The proprioceptalar is visible here in red. The talocalcaneonavicular is imaged here in blue. And when there is distension here at the level of the sinus tarsi, and the distension is such to be visible at ultrasound, you don't have to make a distinction between these two recesses. The point is to understand the amount of distension in the groove of the sinus, delimited by the two bony walls on the sides, the anterolateral process of the talus posteriorly, and the talar head anteriorly. And again, for the subtalar joint, we have a posterior recess, but it's not easy to evaluate. So I think that the best solution is to refer to the to what you see in the sinus tarsi when there is a discrepant finding between the what you see at the sinus tarsi and posteriorly using the posterior medial scan. So these are some notes that are important to remember regarding scoring to make the scoring process easier and at the same time very informative. Regarding osteochondral damage, you have to refer to the width of the cartilage involvement if you have to score the cartilage. Remember that we don't make a difference between full thickness and partial thickness because it's very tricky. In some instances, it may be very difficult to perceive a difference and to understand how much of the cartilage has disappeared over the surface. So it's much easier to refer to the extent in which you see abnormal cartilage over the surface of interest. And when you consider the cartilage pathological, you have to refer to a loss of cartilage of at least 50% of the thickness. Then moving to the bone, remember that bone is scored in 3 grades. Grade 0 refers to a smooth subchondral bone, and grade 1, good things to remember is that you have to score grade 1 when you see abnormalities, bone abnormalities, but you are still able to recognize the surface as such. If the surface is completely deranged and is not longer recognizable, this is grade 2. So this is a simple way to score bone. So these are some notes regarding the scanning technique and the scoring scale to make the scanning process and the interpretation of findings a bit easier. I'll send you some educational material regarding the EDAS system after the end of the webinar through the World Federation. If you are interested in it, you have to contact the World Federation, and the society will provide you with this kind of material. Then I think that it is also important to understand the status of development and the status of use of the EDAS system, and to have a an estimation of it at the moment, trying to understand the various aspects of test performance, and we decided to use the Thornbury scale. That is a 6 tiers level of scale, starting from level 1, technical efficacy, and then moving to level 2, diagnostic accuracy efficacy, level 3, diagnostic thinking efficacy, level 4, therapeutic efficacy, level 5, patient outcome efficacy, and level 6, societal efficacy, to explain where we are with the EDAS. Starting with technical efficacy, so we did our best to make the system as much feasible and acceptable as possible, performed not with high-end machine only, but also with conventional machines, including portable and ultra-portable devices. At the same time, time efficiency is another criterion that may make the system very efficient to be implemented in the daily activity. Regarding the operator dependence of ultrasound and the need of training, we proposed a system in which the technique is strongly standardized, and also the interpretation of findings is standardized, just to avoid errors. In terms of analytic sensitivity of ultrasound, to depict the items that are part of the domains we described before, so informative about the disease activity and osteochondral damage. Remember that ultrasound is able to demonstrate a minimal amount of effusion at the level of the joint recesses. These are two images obtained by the Buenos Aires group, in which there was injection of blood in the joint of a cadaver. And you can see that after injecting 2 ml, the fluid blood is already nicely visible at the level of the anterior recess of the joint. And after 3 ml, you can also see a higher amount of effusion distending the joint recess. Similarly, when we have an osteochondral damage, you can see that the damage, even if it's very limited, it's so nicely depicted when the osteochondral surface is exposed to ultrasound beam, as you can see in this example. So regarding the technical efficacy for measurements, we decided not to use measurements, but to use just a semi-quantitative scoring scale to recognize patterns more than measuring them, because you know that based on the changes, minimal changes of the angle of flexion and extension of a joint, we may have also changes in the shape of the recesses. So precise measurement is not feasible when we examine the recess and we go there and place the caliper to measure their distension. And finally, the inter-observer and intra-observer variability was tested. This also is an important point regarding the potential of reproducibility of results. Here are some papers the result of some papers published in the literature, but there is much more. Remember that the main point is that there are no differences between the profession of the examiners in terms of performance if the examiners are trained. Another important point, the better performance in terms of agreement in scoring may occur among examiners who use ultrasound on daily basis and not seldom. This is very important. So the accuracy of people in performing EDAs is much better, and it's in calibration is also much better if the examiners use ultrasound continuously as part of their daily practice. So these are important points that have been emerged when assessing the inter-observer and inter-observer variability. Then the level 2 is diagnostic accuracy efficacy, and just to understand if ultrasound, if EDAS is able to effectively detect the disease activity and osteochondral damage in hemophilic arthropathy. So in other terms, if there is a concordance with other advanced imaging modalities like MRI in the quality of information. So at the end, EDAS and MRI measure the same construct. So there is a convergent validity between these two systems. And now there are also different papers comparing the performance of ultrasound and the one of MRI. When we refer to synovial hypertrophy, and we refer to something like the area you see in the image related to the olecranon recess, so in which you have a solid tissue located in the recess, not a black effusion, but in general, when we go and scan the joint recesses in these patients, and we see images like this one, we have to realize that these images are not purely synovial, because the synovial hypertrophy may be there, but together with synovium, because synovium bleeds, we may also have coexisting clots, blood degradation products, fusion, some hemosiderin may coexist there. And so we have to realize that the concept of synovial hypertrophy is dirty, is something expressing disease activity in general, and in some sense also under treatment. But we have also to realize that what we see there may include more than one item. There is no need to distinguish them from each other, because at the end everything is part of the activity of the disease process. So this is an example of a paper in which the performance of EDAS was compared with the MRI. And in these papers, the performance of a Ferrari 3 Tesla MRI was compared with a 500 a portable machine. But even with this big discrepancy in terms of technology, at the end there was a perfect correlation between EDAS and the IPSG MRI score for the severity of synovial hypertrophy, and also for the severity of cartilage and bone damage. And this is surprising, because if you give a look to an MR image and the corresponding ultrasound image, ultrasound is more limited. It is not able to demonstrate everything in the joint like MRI. So the cartilage investing here, the articular surface of the distal tibia is not exposed to ultrasound beam. The subtalar joint and the osteochondral surfaces belonging to these joints are not visible with ultrasound. But the fact that ultrasound demonstrate changes located in the exposed path of the joint, and just considering these changes and not the comprehensive problems affecting the joint create a correlation, a good correlation with magnetic resonance imaging. Of course, magnetic resonance imaging is more detailed, so you can measure the length of the osteophytes, you can measure the number and the size of the subchondral cyst. The point is, if we use ultrasound to understand if in a joint, there is no damage. The damage is mild or moderate or severe. Ultrasound can perform fantastically, and the correlation between this technique and MRI is high. There are a tricky question. One of the tricky questions still to solve is how to distinguish between florid synovial proliferation and fibrotic synovium or atrofibrosis. I think that the detection of grade 2 synovium, so huge distension of the joint space, can be considered a conceivable criterion to separate florid from fibrotic, because fibrotic synovium is not so big at the level of the joint recess, and in general is not scored as grade 2. Of course, ultrasound has the weakness not to be able to distinguish hemosiderin, and color Doppler on the other side has many limitations. One is the fact that it has a high inter-equipment variability. The second problem is that microvascular techniques are not sensitive enough. So this is an example of a of an hemangioma of the soft tissues. The hemangioma is a sponge, and if I activate the video, I can see something moving here. These are the sinusoid of the hemangioma, and you see the blood flowing here. But if I switch color Doppler on, I see some color Doppler in the hemangioma, but depicting the big vessels and not the small, and not the sinusoid where the blood flow is very slow. It's almost stationary. So this means that depending on the circulation, ultrasound and Doppler techniques can demonstrate something, but something can be also missed. So the negative predictive value is very low to be used as a criterion to distinguish what is a florid synovial proliferation from fibrotic. And then there is the point of the fat pads. Much interest exists today in understanding what happens at the level of the fat pads. Basically, on the back of synovium, we have fatty tissue. The capsule is far away from the synovium. There is no barrier on the back of synovium. And when the synovium has a bleed, the bleed enters the joint space, that is the point of least resistance to distension, but there may be also passage of blood in the fat pad. And this probably blood there, it's more difficult to remove, and not uncommonly when we see hemosiderin or when we give a look to the fat pads around joints, we can demonstrate changes at the level of the fat pads, as you can see here. So this is not synovium in the joint. This is the joint recess. This is something migrated at the level of the fat pad, corresponding to the deposits of hemosiderin visible in the magnetic resonance images. Similarly, how to differentiate hemarthrosis from synovium. In some cases, it may be not so easy. Remember, there are some findings that can be used for this differentiation. In acute phases, the blood located within the joint may be echogenic, as you can see here, is not very dark, but you can see very subtle echos and suspension there, and this is related to the reflectivity of piles of red blood cells. You can use prop compression to squeeze the blood away, and then at later stages of a bleeding episode, you can also have changes related to the content of the joint recesses. The blood becomes darker and darker, and this is due to the lysis of the red blood cells and to the fact that blood clots are fading out. You can see fibrin strands located within the recess and so on. So which are the main criteria to distinguish clots from synovial proliferation? Remember that synovial proliferation is a wall process. Blood clots are suspended in the recess. They are not, they tend to occupy the cavity, and then they shrink and retract, detaching from the walls. So this is a main differential features to distinguish the blood clots from synovial proliferation. And this is also, this may be visible in macrobleeds. In minor bleeds, when we have a synovial hypertrophy at the level of the recess, the occurrence of a bleed may be more difficult to detect because it could only cause a slight change in the volume of the recess, difficult to perceive, clinically difficult also to perceive on ultrasound. Similar to MRI, for diagnostic accuracy, efficacy, it's also good to compare the performance of EDAS with the AJHS 2.1. And in this case, we expect to have some kind of convergent validity because the two systems may measure the same construct or are also divergent validity because the AJHS 2.1 is a system measuring not just the structural points, but also the function, no? And so distinct components of the joint health. Comparing the two systems with each other, there are some differences. A good correlation exists, basically, but remember that in many cases, when we have a completely negative examination at AJHS, EDAS is able to depict something more. This has been emphasized in some papers in the literature. You can see here a paper published by a group of physiotherapists from UK. Here is another group of Spanish hematologists and physical and rehabilitation specialists. And here is another paper recently published by Carla on children. And if you consider an AJHS score of 0 in the 3 papers, you see that there is a percentage between 10 and 15% of cases in which ultrasound was able to depict something more. So this is an important observation. So this means that if you don't use ultrasound, you can miss a significant percentage of pathologies in the joint. If you compare each individual item of AJHS with the items described by the EDAS score, at the end the correlation seems to be relatively weak. It's a bit better for bone, but for the cartilage and especially for synovium, you see that is weak. And this probably indicates a weakness, an intrinsic weakness of the clinical system, of physical examination in detecting some items related to swelling to the synovium, basically, in which ultrasound is more sensitive and also more objective. It's interesting to read this paper published recently in the literature about the fact that the AJHS is considered, as you know, very time consuming. There is a demand for a shorter system for clinical practice, you know, and some items seems to be not so critical for the evaluation of joint. The ideal that was not discussed in this paper was that the EDAs could represent the basis over which building something more in terms of the information provided by HAHS. So instead of starting the examination of your patient with the physical examination, with the score that may be long to perform, very difficult to perform in some instances, and then going to ultrasound to confirm the results later. It should be nice to start with ultrasound, and then also because in many centers the hemophilia team has no dedicated physiotherapist of people who has an expertise, no, to visit the joint. It would be nice to also to design a system, a more simple system, a simplified physical examination protocol to be used in conjunction with the EDA system. This would be very effective, especially to enable people who didn't receive training to perform an informative examination for their patients. The level 3 is about diagnostic thinking efficacy, no, and this means the certainty, the confidence in the diagnosis. So how many times ultrasound is able to change the diagnostic thinking of the doctors. And a typical example may occur in cases of poor adherence to treatment when you ask the patient about the prophylaxis when you see that there is grade 2 synovitis in their joint. And if the regimen is correct, you can have the confirmation that the problem is related to non-compliance of the patient to treatment. And the ultrasound may be a fantastic test to inform the patient about the problem occurring, and the patient admit after ultrasound the problem. In this case, ultrasound may increase the evidence and the confidence that the patient has a poor adherence behavior. In addition, in the same field of poor adherence, its ultrasound has proven to be a fantastic system to communicate the information to the patient, to convince the patient about the need to respect the regimen of prophylaxis. Another interesting case in which ultrasound was able to change the diagnostic thinking was about the was published by the San Diego group, checking the painful joints before and after ultrasound, and the idea regarding the pathology affecting the joint, if there was a bleeding arthritis, if pain was arthritis mediated, or the idea for the doctors and the patients changed much after the use of ultrasound of 33 suspected cases of bleeding. The true bleeding episodes were 12. So this is a big change in which the role of ultrasound, the impact of ultrasound is also important. In terms of diagnostic thinking, ultrasound was used to describe the clinical status of a group of patients in different clinical contexts. Here are two examples of Nordic studies in patients with moderate hemophilia, with hemophilia B, and all of these studies, so the use of EDAS helped to depict the make clear the incidence, the prevalence of undetected disease in these patients. These are the percentages for moderate hemophilia, and in the paper on hemophilia B, you can also read here some information for which the conclusion was that people with severe hemophilia B suffer from a milder arthropathy than patients with severe hemophilia A. The Spanish group also published papers on hemophilia A and hemophilia B. In these papers, it was noted that people in a tertiary prophylaxis or on-demand treatment actually had worse score at the level of the osteochondral surfaces in terms of severity of damage. And this is for both diseases, and ultrasound was believed to be very important as a tool to improve the patient management. Lastly, moving to the therapeutic efficacy, we are now at level 4 probably. And so we are now trying to use ultrasound to identify changes related to therapies, to check the result of therapies. It's a field that is not difficult. It is not easy to address. But in general, remember that when you have grade 2 distinction of the joint recesses by synovium, this is an alarm, and this sign in general should serve to go more in depth and to make an accurate check of treatment plan. In general, with grade 2, when this finding is unexpected, when non-compliance is excluded, the ultrasound is the detection of grade 2 may be associated with the need to change something in terms of treatment or in terms of patient management. For grade 1, the information has a milder significance. Probably it's something to suggest a closer follow-up for the patient, but everything needs to be very personalized depending on the patient. And grade 0 is also interesting because this means that there is no activity at the joint level, but this is probably also a way to to make a downward adjustment of prophylaxis to save some doses and to use them for subset of patients at higher risk of hemorrhage. Everything has to be discussed about this point, but of course, when we evaluate patients systematically to identify changes related to the disease and to identify changes in therapy. I think that is good to have anytime a full joint status assessment, including not just ultrasound, but also clinical examination like AJHS. You have to complement the scoring numbers with the images, with video clips, and of course, functional tests and physical assessment is also relevant to be included in one. As if there is a change, the change may lead to an upward therapy change, to a lifestyle change, to a closer follow-up. Anyway, this depends on the on the person, depends on the clinical context and the disease phenotype. I think in cases there are no changes, ultrasound can store the information and can be repeated in the sixth joint at least once a year for having a baseline examination. In case and to be even more sensitive to demonstrate some changes that has occurred in after changes in terms of management and therapy. Don't forget the ultra-portable devices. Now they have been introduced in the last years in the also in the field of hemophilia to promote some kind of home-based strategies with a democratization path in which the management of these devices passes from the hands of doctors to patients. And the way to manage these devices can be through applying a teleradiology system, no, with the real-time guide from remote by an expert. But also there are other models to be applied for that. Nurse visit, patient self-assessment with the images sent to the cloud, and then check it with the doctors in charge of the patients later on, or artificial intelligence-based devices in which the detection of bleeds becomes automated. So all of these strategies are have the aim to take ultrasound close to the patient anytime. So when there is a problem occurring, the image can be obtained in a very short time, and based on the image, the decision of the therapies could be adjusted properly. So this is is a very near future, and probably we'll see interesting application and in the next years regarding the use of these ultra-portable devices by patients. So thank you very much for your attention.
For Gianluigi, I would like to say thanks to Carlo. Thanks a lot for the really beautiful, amazing, and comprehensive presentation. And I would like just to share with him a very quick comment, considering that a few days ago I met a full professor of sociology, and we started discussing about how innovation can be defined. And based on his experience, on his position, he clarified that innovation it's not only the introduction of a new technology, but is often the new application of an existing technology. I think, thinking about his words, that head-US system is the perfect demonstration of an innovative approach. Joint ultrasound has been existing since years, decades, but now we are approaching, 10 years more or less, we have started approaching the screening of patients with hemophilia with ultrasound, and this totally changed our mind and our way to approach hemophilia care. And I want to thank Carlo Martinoli for all his work in this field, his continuous support in this field. I think we don't have much time for questions, but it's mandatory to say thank you for all the energies you are devoting to this topic. So thank you very much.
It's a question quick to Dario, please. I know that there is a very important paper is being now for pre-proof, which I think, Dario, you are the first author of that, but it contains also Carlo, it contains also Gianluigi. Is this out or not yet?
Yeah, it's out. It's available on PubMed, on the JTH website. It's available, and it's also open access, because we have preferred to publish it as open access just to give it the maximal availability for access. Yeah. Because it's the first, all in all, the first study providing the evidence of two things: of the results of an intensive replacement therapy with factor VIII on hypertrophic synovium, and also the proof of the longitudinal assessment with the EDUS system. And this is the clear advantage, also described by Carlo in the last few slides of his presentation, is the proof that we can do it and we can appreciate the change in hypertrophic synovium.
Thank you very much. So for our participant, this is really a very recent paper, which is really very important also. It is in the Journal of Thrombosis and Hemostasis, and the title of this, it is Intensive Factor VIII Replacement in Hemophilia Patients with Hypertrophic Synovium, a randomized study. So really, since it is open access, we would like also our participants to log into the Journal of Thrombosis Hemostasis to get it, or maybe also we can get it and send it to you as PDF in the future. Thank you very much, Dario, Carlo, for this important paper. Back to you, Jay.
Thank you.